Hi, my name is Erica Richards, and I will be doing my Capstone poster presentation on a newborn preterm infant. Starting with the background, my patient, she was a female newborn preterm infant of 24 completed weeks and 5 days of gestation with a corrected gestational age of 30 weeks and 1 day. The patient was admitted by emergency air transport from a town in the Midwest due to extreme prematurity. The patient had a 1-minute APGAR score of 2, a 5-minute APGAR score of 5, and a 10-minute APGAR score of 6. Her birth weight was 0.88 kilograms or 1.94 pounds. She was intubated immediately following birth and received her first dose of surfactant replacement therapy at 1 hour of life and her second dose at 19 hours of life. Umbilical, arterial, and venous catheters were placed to transfuse blood, monitor blood pressure, draw labs, administer medication, and administer total parenteral nutrition. She was extubated on day of life 18 to NIPPV, but reintubated on day of life 26 due to her increased FiO2 needs. Chest radiographs were taken and were positive for persistent bilateral whiteout in lower lung lobes. An endotracheal tube culture returned positive for methicillin-resistant Staphylococcus aureus. Blood cultures returned positive again for methicillin-resistant Staphylococcus aureus. The patient was diagnosed with neonatal sepsis. She received antibiotic therapy of vancomycin and ceftriaxone. She was Her history further includes bronchopulmonary dysplasia grade 2, ostium secundum atrial septal defect, anemia of neonatal prematurity, GERDs, retinopathy of prematurity, hyperbilirubinemia of prematurity. Maternal history includes IVF therapy with multiple previous spontaneous abortions. Mother denies history of tobacco, drug, and alcohol use. Mother and father of patient are married and live together. This is their first baby, and prenatal care was established at 4 weeks of gestation. Moving on to nursing assessment. For my nursing assessment, my patient vital signs were blood pressure of 74/50 with a MAP of 51. Temperature was 37.7 degrees Celsius. Respirations were 26 per minute. SpO2 was 96%. Heart rate was 148 beats per minute. For her head, anterior fontanelles were soft and flat, face symmetrical with no deformities noted. Her eyes, eyelids were clear, no conjunctivae noted. Ears appeared normally developed. Nose, she had patent nares and slight redness below septum due to NIPPV. Her mouth, mucous membranes are moist pink with no deformities noted. Her chest and respiratory, she had, upon my physical exam of her, she had periodic breathing with bradypnea at time of assessment. Lung sounds are clear and equal bilaterally. For her cardiac, rate and rhythm are normal sinus, normal S1 and S2 sounds. However, there was a 2 out of 6 systolic ejection murmur heard. Pulses were normal and capillary refill was within normal limits. Abdominal, her abdomen was soft, non-tender, symmetrical, no organomegaly, normal bowel sounds were present. Genitourinary, she had normal female features for gestational age and a patent anus. For her extremities, they were atraumatic in appearance, without tenderness or deformity. Full range of motion is noted to all joints. For her neuro, appropriate for gestational age. And her skin, pink and intact with no lesions noted. Moving on to her medications, she was on caffeine, which is indicated for the stimulation of central respiratory drive and to improve her diaphragmatic expansion. She was on Tylenol, indicated for fever reduction and pain control. She was on vancomycin and ceftriaxone, indicated for her MRSA infection. She was also on ferrous sulfate iron supplement, indicated for her neonatal anemia. She was on sodium chloride, indicated for to help promote her electrolyte balances. Zinc acetate was also on her MAR, indicated for healthy growth and development. She was on a multivitamin, again indicated for healthy growth and development, and she was also on Desitin and water wipes, which is to help prevent skin breakdown in her diaper. For labs, we have a red blood cell count of 2.81. Normal range is 3 to 5. For white cell blood count, we have 15.1. Normal range is 5 to 19. Hemoglobin, 9.6. Normal range, 10 to 16. Hematocrit, 28%. Normal range for a newborn is 45 to 61%. Platelet count was 434. Normal range is 140 to 400. She did have protein in her urine with a protein of 30. There should be no protein in her urine. That should be negative. She did have blood in her urine. She had 3 to 5 was her specific lab. It should be 0 to 2 would be expected. Creatinine, she had 0.37. The normal range for a neonate is 0.10 to 0.36. Her chest radiograph during my time of care for her was improved. The whiteout was no longer persistent and improved in her lower lung lobes. Blood culture, however, was still positive for MRSA infection. So as you can see, her labs indicate abnormally low red blood cell count, hemoglobin, and hematocrit. This may be related to her history of anemia, neonatal anemia. Her white blood cell count was within normal limits, but it was on the high side. It might have been higher previously. She had been on vancomycin and received her 4th dose in my care due to her staph infection, her MRSA infection. Labs also indicate potentially impaired renal function, as you can see from the creatinine, her protein in the urine, blood in the urine. We weren't entirely sure as to those labs, but they may have been related to noxious insults, to her problems with hypoperfusion, her time on the ventilator and not getting oxygenated well enough, and nephrotoxic agents such as vancomycin, which can be toxic to the kidneys. For nursing diagnosis, I have 3. My first one is impaired gas exchange related to extreme prematurity, as evidenced by bradypneic spells of less than 95% SpO2. Acute pain related to infectious process is evidenced by NPAS score of 5. Risk for interrupted family processes related to extreme prematurity. Moving on to the planning stage, we plan to administer maintenance caffeine to stimulate central respiratory drive and improve diaphragmatic contractility, administer vancomycin and ceftriaxone therapy for infection for 7 to 10 days based on chest radiographs and other clinical manifestations, administered PRN Tylenol to maintain an NPAS score of 0 to 3, but less than 3, administered non-nutritive sucking interventions such as pacifier use to decrease stress response to noxious or painful stimuli, promote parental participation in patient cares, patient soothing, and other measures to facilitate parent-infant bonds such as skin-to-skin contact, and finally offer support group, counseling, and social services resources to parents. Moving on to the implementation phase, within a 3-hour period, the patient had 4 desaturation spells lasting in duration of 30 to 45 seconds each. Patient received a caffeine bolus in addition to her maintenance caffeine to stimulate her central respiratory drive. Vancomycin troughs were drawn and evaluated preceding the administration of her 4th vancomycin dose. Patient received Tylenol for a mild fever of 37.7 degrees Celsius upon physical assessment. Patient received NPAS score of 4 due to inconsolability and agitation during physical assessment and care set. Patient received non-nutritive sucking aid, such as a pacifier, for the duration of her physical assessment and care set. Encouraged and educated parents on importance of holding, soothing, and participating in patient care sets to facilitate bonding. Social worker provided meal resources to parents during visits to promote longer, uninterrupted bonding opportunities between infant and parents. Additionally, parents were informed of resources such as shower and laundry facilities and meal resources available to them during their stay. Health promotion and disease prevention considerations. Contact precautions were initiated due to her MRSA infection. Cultural considerations. Her parents were of the Christian faith and shared that with us and their interest in meeting with a chaplain. For coordination of care considerations, report was given and taken at patient bedside with parents present. Moving on to evaluation. Patient did not experience desaturation spells after caffeine bolus. Maintenance caffeine was continued as ordered in addition to that bolus. Vancomycin troughs were assessed and within therapeutic range levels, so the fourth dose of vancomycin was administered. Mild fever improved to 37.2 degrees Celsius upon reassessment 2 hours after administration of Tylenol. Patient displayed interest and engagement with non-nutritive sucking aids, such as the pacifier, during physical assessment and subsequent care sets. Patient displayed improved physical and emotional regulation when held and soothed by parents during and in between care sets. And parents were able to utilize meal, shower, and laundry resources provided to them in order to facilitate those longer stays with the patient and promote that bonding. Thank you very much for watching my presentation. My name is Erica Richards.